That was 2 minutes we'll never have back. All right, we're finishing up. There's, thank you. I never, same thing at home. This is the very end of the Cowan chapter. It actually had some interesting stuff that's going to lend, kind of goes into what we're talking about in the very next chapter, which I think is interesting. So, I mean, this is where, yeah, well, these are, because we're going to be talking about host interactions with pathogens, with viruses and bacteria. So it's interesting to just sort of frame it this way. There's a few little slides I'm basically reading to you, and I'll make some comments on. So the effects of the drug on the host must be considered. So that's something I understand. But even though it's the right choice, there's so many variables. Can they tolerate it? What other medicines are they taking? How will they handle it? Will they take it in the first place? What happens if it makes them sick? Can you still convince them to take it? So, but the trouble is that selective toxicity is an ideal. It's something we strive for. There's very little of it. So 5% of all people taking an antimicrobial drug will experiencing some kind of side effect. It's a matter of degree. So, I mean, yeah, and that's really from a perspective of trying to, I always think forewarned is forearmed, to use yet another cliche. People don't like surprises. Let them know what the side effects are so you can understand that there's an important reason to take this. If there's side effects, let us know. We'll deal with it. So, just for instance, these are the areas, and you'll hear these terms a lot. To me, the most common by far, gastrointestinal, but they're not limited to that. Liver and kidneys, certainly, because that's where they detoxify or break down a lot of these substances, so they're at risk. GI, because a lot of things irritate the gastrointestinal lining. Hopefully not in this area, but unfortunately there are a lot of antibiotics, and this is the one where I remember mentioning something called chloramphenicol, where it suppressed the bone marrow. So that's one of the things you know, an old mentor of mine said, and a relatively young guy at the time, not a whole lot older than I was, said any drug can cause any side effects. The fact that it doesn't, it's the warnings. If you go into pharmacology, for many of you in nursing, and it goes, these are the side effects. The side effects. They list them pharmacologically. We list them based on the ones that are most frequent and less frequent. Anything is possible. The fact that it's not on some table that's with the package information or the pharmacist tells you about does not mean it can't occur. And all the other ones, as you can see, are there. So again, major adverse reactions. So typically with the penicillin family, we're thinking about allergic responses, rash, hives, watery eyes. They're in that. Okay. Now some of these, when we start to substitute the penicillins, now we get more into the family of things with diarrhea and other gastrointestinal effects. Cephalosporins, again, this is, you can see there are some issues. Even though they are the most prescribed, it doesn't eliminate the likelihood. So you can't just say, oh, we don't usually have problems like this. For many of you in the position, when someone comes to when they have a problem, at the very least, you have to be receptive and not judgmental about that. You're going to find some people have problems with everything. They're there. The sulfonamides are a really good category. I can tell you this from experience. When they happened to give my grandfather that back in the 50s for a kidney infection, and he had a crystal in his kidney, and he had the kidney removed. That's why they shied away from using all the sulfa drugs like Bactrim and Septra that now have become so valuable in treating MRSA. So I mean, it was. I'm sure they refined the product and changed it, but that was a very interesting thing. Polymyxins, the colistin is a drug of last resort. I don't see a lot of problems with Cipro or others that are in this family, but all of these are sort of generic problems. The GI, I had a lady who was on it for quite a period of time with an infection, and thankfully it resolved, but gastrointestinally it was a pain. And it was one of those, she needed to be on it. She was allergic to penicillin. It was a kind of infection, was very responsive, and fortunately it worked. And rifampin, I don't think you'll have a whole lot of thing with, because we're using it for tuberculosis patients. Already we have a risk element that's there. Other things, amphotericin B, one of the reasons we don't use it is the side effects. Same thing here. Uh, for me, the major problem with Metro, even though anything can happen, traditionally it has been headaches more than anything else. And then you can see, and again, you can see some of these days, Ciclovirs, yes, they have some issues that are there, but in general, that has been the most successful category of antivirals because, again, they are not activated in normal cells. It doesn't preclude side effects. Allergies, different. An allergic response means it's been triggered. It's an overly exuberant or an irregular response of your immune system. That's what an allergic response is, period. Everything else is a side effect. So it stimulates an allergic response, and it can be provoked by almost anything, either from the medication that one is taking or as the body breaks it down. That's what a metabolic alteration is. A lot of products have what we call active metabolites, meaning that there's still things that they do to us, even though our bodies have started to break it down. Very concise. Allergies have been reported for every major type of drug, but an allergy to penicillin is most common. And again, just like you've been learning about in my A&P, and many of you are in that A&P section, okay, sensitization is first contact, and then after that, that second exposure, anything can happen. Just in the process of finishing, concluding that immune unit, and I mean, I would take that to heart, but I think it's an important statement that's there. And then we'll look at in the next chapter, we're going to start looking at the normal microbes. And one of the problems is they're basically beneficial bacteria, even though some of them by definition are disease causers. But if they're in the right place, in the right position, it's like Staphylococcus aureus in your nose. That's where it grows. It's supposed to be there. We have Staphylococcus aureus in our respiratory, so they're in our throat. It doesn't mean they're causing damage. That's the appropriate place where they are. It doesn't mean that they're not pathogenic. And so, unfortunately, this has been the big problem with using excessive amounts of broad spectrum antimicrobials, what we used to call shotgun therapy, and people still do. They're destroying the good guys. Good guys covering up receptors for bad guys. Good guys eating up resources for bad guys. Good guys suppressing bad guys. Okay, and this is what happens when it occurs. C. diff is a classic example of a superinfection. You have broad spectrum antibiotics destroying the normal gut bacteria. Now the endospores, which C. diff have, don't have any competition, so they are now in an environment where they can flourish. And all of a sudden they start to flourish and they begin to produce a toxin, and that toxin is nasty. Okay? So urinary tract infection caused by E. coli treated with antibiotics. Okay, what are we doing? This is the classic example. The antibiotics, the number one bacteria that we have in the female reproductive system that guards against infection is called lactobacillus. Okay, lactobacillus, and we'll learn about this when we look at urinary tract infections, is the basic defense in women during the childbearing years. What mucus is other than those years. Lactobacillus is abundant and thrives on glycogen. Estrogen makes glycogen in cells in that area. They ferment the glycogen. They make scads of lactic acid. The acid is very uncomfortable for any type of invaders. But this is one of those bacteria that you take any antibiotic, particularly a strong one, they get rapidly destroyed. And about a third to one half, perhaps even more, of men and women harbor candida, a common yeast. Okay, and they get a vaginal yeast infection or oral thrush. I was predisposed to oral thrush when I was taking all those agents I was taking for my arthritis that were suppressing my immune system. Every so often, all of a sudden I have a terrible sore throat. The next thing I know, I'm having to take 5 lozenges a day, let them dissolve in my mouth. That's the treatment for it, by the way. And then all of these antibiotic-associated colitis, again, that's what I'm talking about with C. diff being able to have its rear its ugly head. This is the idea, the shotgun approach. this led to so many problems, and because we were constantly exposing these bacteria to these, eventually they're going to develop resistance. And so and the approach was so wrong. The approach that I learned in school 50 years ago, and it was used for a very long period of time until we began to realize this. And the biggest single problem we have in treating infections, bacterial infections, is the running out of antibiotics and looking for alternative means. That's one of my points I'm stressing about in this. For instance, that's absolutely true. If you did not know it, there's a lot of countries you can just go in and buy antibiotics. If you've traveled in Latin America, if you've traveled in Europe, it's not hard to find them. Traveled in Asia. I mean, and are they? Some of them are the real thing. Some of them are generic. They're all real, but some of them are just generic. I remember my son calling me from Thailand. Oh, Dad, you want me to bring back a couple of Z packs? And he was on a mission there in Thailand. I think one was on vacation. And he goes, yeah, I Z packs, a couple of this, a couple of that. Just have them on hand just in case. I said, that's nice. I said, but I don't think it's a great idea. He said, because they're probably just generic equivalents, but it's easy to come by. So that really ends our little unit on antibiosis. And really, what it dovetails into very, very nicely is effectively the first sort of the introductory component, this interactions between microbes, and it covers bacteria, viruses, everything. After this, we're doing strictly, and so this is basically how generically how things infect you, how they damage you, how we look for how they enter, how they exit, how we have to deal with some of these things epidemiologically. So there's a lot of material in this particular chapter. After that, we're going to start diseases. So, and we have comparatively limited time left. I'm going to try to get in at least 3 or 4 units on diseases. I always get respiratory, skin, and genital urinary diseases. And after that, we'll see what happens. I try to get wound infections in at least. So that's what you're stuck listening to me. To that end, I'm thinking, since this chapter is on the next exam, I'm thinking that it's going to take me the rest of this week and at least maybe through Wednesday of next week. At least a week, maybe 4 sessions to do this. We're going to do the test for 1. We'll do it on Blackboard. But I'm not going to do it in class on Blackboard. We're going to have to figure out a certain window of time, probably in an afternoon or evening, to do this. Think about what might work best for you. Discuss it on Friday. I know you work on Friday.
I work Monday, Wednesday, not Friday.
Oh, really? Then we'll make it on Friday.
Wait, this Friday?
No.
No.
I already started it.
Okay.
We're not going to make it on Good Friday. We'll figure it out.
Okay.
I'll make a note of that.
We make Thursday after 2. Yeah, Thursday.
Are we looking at Thursday after 2?
Thursday.
Well, anybody object?
Could you just have it open all day instead of after 2?
I can arrange a fairly large room. Yes, ma'am. What are you doing on Thursday?
I work at a hospital. I work Thursdays. I work from 2 to 11. Can you keep it open all day? Yeah, keep it open all day. If you do it all day, Thursday, open all day.
Okay, I'll think about it.
I like your shirt today.
Thank you.
Thursday would be great.
This is a shirt. My hand, I have a little arthritis in my fingers.
Right.
Yeah, I do. Affects my golf game. I don't want to hear it. You're already a troublemaker. Cute, but a troublemaker. Yes, dear. Pardon me? I do not know. I will look. Is it on Blackboard? Anybody? If it's not, I can find out right away. If it's not, I'll make sure it is. I could be wrong. So hold on. We have a request to make sure it's on Blackboard. Don't start with me. Hey. It should be. If it is here, it should be under Unit 3, and it may not be. You may be very right that I did not include this as yet. I do not have a handout with it. No, it is not. Let me for everybody. Let me add it right now. I'm glad you reminded me. Thank you. So we call these host microbe interactions. Not very good. My wife is throwing things at the TV set because the pirates are sucking. She's very upset. So you better hope that they win. Skeens is pitching this afternoon because my wife is threatening trauma to the TV set. Yeah, Skeens pitching. Yeah, 110. No, I know. The bullpen El Stinko. And they can't hit either, so why bother? Moving on. So this is the start of this particular chapter. It starts somewhat generically. So we're paying a lot more attention to all we call the human microbiome. There's a lot of variation where you live, what your hereditary background is, cultural things, geographic things, climate things that have to do with it. And because we interact, all of these microbes that are found on, and when they say in, by and large, you're talking about linings. When you go on and you look at this PowerPoint in the chapter, it talks about that we're finding microbes in spaces now with advanced technology that we didn't, things that we thought were, quote, we call sterile tissues. That, and you're like even in the bloodstream or in the central nervous system, evidence of DNA fragments that suggest that there were microbes in there at one point in time. It's very interesting. And as we learn more about that, so really it is a critical area to understand why people get certain things, why they don't. It's very, very complex to understand. So they colonize us long term and do not cause disease. So you can call them normal microbes. I grew up on the term normal flora, FLORA, because they have, bacteria have cell walls. Everybody thought they were plants. So they went to microflora or normal flora, and now it depends on. I do not know what I haven't worked in a hospital in 25 years, so I don't know what the terminology that you will encounter is. But whatever the modern terminology is, that's what you'll come to know what it is. And so the whole idea of what's an infection, the fact that they are normal does not mean that that do not cause disease is probably a little too generic. Almost any organism has the capability of causing disease in something we call a compromised host. A compromised host, someone who is at risk. I mean, even something that's normal. That's what you're going to see a lot of in the hospital. You're going to see Staphylococcus epidermidis on 100% of our skin, 100% of the time. Someone who is compromised, has a wound, has an ulceration, has a bed sore, and all of a sudden they've got a whopping infection that you're having a darn hard time treating. So I wouldn't paint so much with a broad. Under normal circumstances, no, they don't. So the microbes, what makes an infection is, yes, they get past your defenses. They enter in tissues where they should not be. They begin to colonize and multiply, and that's an infection. Okay. And so and particularly so we can look at it that way, and then we can assess what the degree of disease that's involved. When cumulative effects of that damage, how they disrupt tissues and or organs and things like that, then we can determine the extent of the quote disease process. Okay, that's there. I don't want to get too definitionally about this. From a test perspective in this chapter, I'm interested in definitions more about epidemiology because they're very specific. or maybe some aspects of disease here than what makes an infection or what makes a disease. Okay, and an infectious disease, pretty straightforward, disease, a pathological or disease state, and the word directly sort of sums it up, are microorganisms or their products. So that's really, and understand that doesn't mean infectious diseases by definition are not necessarily contagious diseases. So understand that. I mean, we all hear about tetanus and tetanus shots. Tetanus is not contagious. Deadly. If you have patients dying of tetanus because they didn't have the immunizations and someone didn't recognize it, it happens every so often or relatively rarely, you can't get it from treating them. It doesn't work that way. So I understand that we misunderstand things, and how disease, and this chapter is good because how diseases spread really influences caregivers, whatever your status is of a caregiver, whatever level, as to what your precautions are, how to approach it. What was I watching? I was at the gym last night, and they had some kind of stupid doctor comedy show on after Jeopardy. Not that I was watching either of those. But of course, I got Final Jeopardy again. Never miss. And as long as it's something, more than 40 years old. And they're in there, and it's whatever this comedy is, St. Dennis or some stupidity of that. And everybody's got gloves on. We didn't wear those in the emergency room. We didn't routinely go into patients' rooms wearing gloves. Heaven forbid, we touched them with our skin. To understand, that was a long time. That was 50 years ago. I'm still here to tell the tale. So obviously, it's not like magically the world changed. Though a lot of people think it has. So understanding when was the appropriate time to use protective gear, when to wear gloves, all of those kinds of things matter. And that's what this chapter is a little bit about. So years ago, and not that many, within the last 20 years, trying to characterize all the microbes. This was the microbiome project. We were able to, we have much more impressive computers and genomic tools. So we could, we have the ability to really analyze this. I mean, they thought when they were back in before the year 2000, they were going to analyze our DNA. I mean, with the age of computing, they was going to take people 20 years. Well, all of a sudden, magically, it took 2 years as the computers evolved. So we have, and I've seen different numbers. This is as good a number as any. I'm not going to ask you. We have about, according to this text, about 21,000 protein encoding genes. Everybody, you are what your proteins say you are. That's what genetics are all about, the proteins we make. That gives us our characteristics, that produces the enzymes that really make us whatever we're going to be. Okay? The microbes have millions of these. They're basically everywhere, even areas where we thought they were sterile. For instance, per gram of feces, I mean, a gram doesn't weigh that much. An ounce is 30 grams, more roughly 28 and a half grams for a solid ounce. Imagine how many viruses we're shedding. Okay. And we all seem to have, to some extent, we're not all true asymptomatic carriers, but we all have the capability of being what's called an asymptomatic carrier. Meaning we don't have the disease, but we have potential to spread it to somebody else. That's there. A lot of times it's on an area, let's say if it's in our nose, like Staphylococcus aureus. I mean, it's not necessarily affecting us, even if it's MRSA, because that's where it grows up. That's where it's supposed to be. But what happens when you walk into a patient's room and you're going to treat them, and all of a sudden you start sneezing at something? I mean, now you have to be cognizant of what I have to do. I better cleanse this area. If I feel like I got a sneeze coming on outside, I've been sneezing a lot today, get the mask on. And heaven forbid, don't leave the mask on once you sneeze into it. Have a bunch of them in your pocket and change them and get rid of them. I don't know why people don't do that. Okay, So a lot of these things, and we've looked a lot at gastrointestinal. There's even they talked about bizarre things in gastrointestinal health, like fecal transplants, because there's a lot of healthy organisms that are in there, and we seek that's what probiotics and prebiotics are based on, being able to utilize, the advantage of healthy microbes in you. So look at this. So we always knew that these harbored normal microbes, your skin, mucosa, the linings, upper respiratory, GI, all the way. The external portion of the urethra, male or female, external genitalia, all the time. Vagina, external ear canal, external areas of the eye, the lids, the conjunctiva. We know that they're there. These are exposed surfaces. They're supposed to be there. But look at this. Even in the lower respiratory tract, you did respiratory a little bit in lab, correct? Did Dr. Robbins talk about all those macrophages that are deep inside the lungs? You have type 1 cells and type 2 cells. Is this ringing a bell? You went to bronchi, right? Did you get to terminal bronchioles?
Yeah. It up, but he doesn't say anything.
You touched on. Okay.
And
You,
he says about macrophages more about the surfactant that the cells secrete.
yeah. Okay. The surfactant are type 2 cells. The type 1 cells are the basic lining cells. Additionally, there you have millions of macrophages. Okay. What they do, and we'll do this in respiratory in my class, is what happens, everybody, is they are gobbling up debris. It's there. I mean, you would think if they're there gobbling up debris, I likened them to it. And I'll do this one again. So anybody who's not here listening to this, don't ruin it. They're like one of those little Roomba things. You know what I mean? People have, you're sitting in somebody's house and all of a sudden something hits your foot and it's not a cat or a dog. Some stupid thing that they've got. My son and my stepson and my stepdaughter-in-law, that's their house. They're constantly working. Like they have like 5 floors and have Roombas alert. So look at this, the bladder. Not just now, and the urine. We used to think that this was not an area where we found, but we know now that they're there because we can analyze better. Breast and breast milk, amniotic fluid, DNA has been detected, brain and the bloodstream. That's remarkable because we have the technology. It doesn't mean that there's infection present. It's just that we have to understand that maybe these are all normal findings. So how we interpret them is really something that hasn't been established yet. So we have a variety of environmental areas, as you were saying. You did digestive yesterday in lab, right? For you had lab. 2 different pHs. The stomach is acid. Small bowel is alkaline. everything in your digestive tract is pH controlled. So you have different pHs, a lot of variations throughout. They displace one another. They cover up sites of attachment. There's different environments that are there. And that's the whole idea. The beauty of these microbes, the normal microbes, they protect us. That's why I raged on about, people incessantly washing their hands, showering 63 times a day. I mean, you and I both know plenty of people who, goodness gracious, all they do is shower. So I have a stepson like that. Our water bill went up when he was living with us for a while. He wanted these 25 minutes in the shower, more than once a day. Please. I'm just going to give him the difference. Here's the average water bill. Here it is when you've been staying here. Here. What's the money? So when they talk about something being commensal, it means you have a commensal relationships and mutual relationships. They tend to benefit one another. At the very least, they're not harmful. There's a couple of different terms you see when they talk about various kinds of symbiotic relationships between us and organisms. Mutualism effectively means we live at peace with one another, and effectively we both benefit. They're there keeping away the bad guys. We're providing them with basically nutrition and space. So, and commensalism indicates at least one party benefits, but the other party isn't harmed. So there's some fine definition. What a parasite is, when we're talking about bacteria, viruses, those are things that flourish, and in the process of flourishing, we are harmed. The host, us, is harmed. That's a true parasite. The term parasite can apply to a bacteria or a virus or any invader, but when you hear the term parasitic infection, it's a little less generic. That usually means something that's eukaryotic. Something like malaria is viewed as a parasitic infection. So you have to understand the context. And that's something I'm sure you're going to see. So if you see the term parasitic in certain contexts, look up to see if they're not trying to, well, it's flourishing and we're being harmed. Typically, it means it's a eukaryotic, so fungal infections, protozoan infections, those kinds of things, worms, those would be considered parasites. And it's almost, typically, you'll even, if you go to take your stool sample to the vet, what they would typically do is they check it microscopically for what's called O and P, ova and parasites. See if your dog has to have some kind of worm, or your cat, or things like that. Yeah. Moving on. So, obviously, aging and extreme. So, both of these things, whether it's post maturity or prematurity, are problematic. Our immune systems are not particularly strong, or our defenses when we're born, and they weaken as we get older. Okay? Obviously, we'll talk about various, when we looked at this virus wise, there are different things that play a role with regard to the immune system. This is something we're getting to in lecture probably today. When we're talking a bit about immunological disorders, be they autoimmune or acquired, things like that, viruses, etc. Any type of interaction with, whether it's any kind of surgery, and particularly things like transplants, underlying diseases, any kind of cancer, diabetes by its very definition is it impacts your immune system, much more predisposed to infection, and your liver is the big detoxifier. If your liver is not functioning well, you are not going to be functioning well. Stressors, various types of agents that we take. Pregnancy alters everything. There's so many different things. These are all a myriad of factors. And anytime someone presents with one and you're involved in a clinical setting, you got to be, obviously, say to the back of your mind, go, I have to be more aware that for whatever reason, this person is to some degree compromised. The healthier someone is, the less likely they're going to have problems. It's just the way it is. Unless there's a genetic predisposition to something, but typically, the idea of having overall health plays such a significant role. So even the intrauterine area, the placenta harboring a small but significant array of bacteria. And these are things we didn't think about. If you think of anatomically, we're dealing with effectively an opening from the exterior, and the guard during pregnancy is a mucus plug. I would not consider that a severe, unable to invade past barrier. It's more of a barrier to fluid, I think, than anything else. So we know, and for years we felt that the original colonization of a newborn went with the vaginal birth, was really when everything started. So we knew that trip through the birth canal was significant in the start of colonization. That's why it was so important to be aware prenatally, if someone's going to deliver vaginally, of the presence of, let's say, a first infection, active herpetic infection, active genital herpes, active HIV. All of those types of things are very significant, because we realize that with treatment, we can eliminate a lot of problems. It's a unit that I go into a little bit when we talk about genitourinary infections here toward the very end of the term. But to understand that's why it's so important to get a history and get these things treated. To this very day, I can remember the class I was doing I do the same micro wherever I would teach it. I was teaching one of my last times, maybe 7 or 8 years ago, at CCAC in North Hills, in McCandless, where I taught for many, many years. And I was talking about someone had not, beginning to deliver without having had a significant degree of prenatal care. And this gal worked Fox Chapel, very affluent area, for a gynecologist. Oh, that would never happen. Nobody was like, no one would do that. I went, hello? In Fox Chapel, you're probably right. And I said, but in real life, it doesn't work that way. We worked in an emergency room in the inner city. We had girls coming in crowning who hadn't told mom and dad. They were just gaining weight because they were afraid of the reaction that was going to occur. That's part of the problem. So adequate prenatal care is so significant. Fortunately, these babies did not turn out to be at risk, but we certainly had babies who were being born before we even knew that that we had a disease called HIV or AIDS, that were going undoubtedly contracted it because that was the population we were dealing with, a terribly ill population. So just little things like that. So there's species that protect. Lactobacillus provides the baby with enzymes to digest milk, which aren't that terribly abundant. There's a lot of difficulty with drinking milk long term, as most of you will know. From a nutritional standpoint, why typical milk, we have to use different types. Not my area of expertise. So you can see human milk contains around 600 species of bacteria and sugars the baby cannot digest, but are digested by healthy gut bacteria. And depending on the child, if you're like my kids, all of them required special formula. And being, and my wife, my first wife, obviously being with all three children adoptive, she was unable to even try to induce anything resembling nursing, although she tried. So these are just some of the areas that you can see. And this is the other things where we get it from the people who interact with, even in the nursery, even with all of the personal protective equipment, you're still in contact that are there from the environment that they're in. There's just so much, and it accumulates over time. And it's very, very specific going long term. Okay. And I make a big deal out of it because I talk about it because I like history. Is the whole idea of the hygiene hypothesis. Let your kids get dirty. Let them play with other kids. It's going back to COVID 101. Every time I see a kid with a mask on, if there's a medical reason, I understand that. Please, driving me crazy. Let them be kids. Because, then their immune system's not ready to meet the challenge of something severe unless it's met ones that are less severe. That's my 2 cents. Okay? And I'm not going to ask you this question anyway, or breast milk. No. I'm not going to differentiate. Colonization. So here's this pathogen. A microbe whose relationship with its host is parasitic. It flourishes while it does you harm and results in an infection and disease. Disease causing means what pathogen, injury or damage causing. So potential to cause not just disease, but damage. Patho means damage, not necessarily infection or disease, but damage. Okay, true. And the true pathogen is the ones that are capable in healthy persons with normal immune system. That Staph aureus that's in your nose, and all of a sudden you cough or sneeze, and you happen to have a cut or a scrape, and all of a sudden it gets in there. Even your own can cause a disease, much less someone else's. Versus the opportunistic, what I was talking about before. Given the opportunity, it can cause problems. When the host defenses are compromised, limited, damaged, it can still be healthy. It can be during a pregnancy, but there's alterations when the pathogens become established in a part of the body that is not natural to them. Where they're not normally something that can grow in your throat or in your nose, all of a sudden go somewhere where it shouldn't be for whatever reason. And a classic example, if we're talking respiratory coughing or sneezing. And then we get in that whole thing about how things that we touch and things like that. Keep saying it again, 5,000 to 8,000 times a day, we touch our face. Which means we can inhale it, we can swallow it. You don't know it. I look around the rooms whenever I make that statement and kind of, guesstimate and see how many people have their hand up. Like you, it's okay. But you were leaning like this before, Allie. Nobody touched Allie until she showers. Nobody thinks you're funny. One of my favorite words, virulence. To me, virulence, they've given you a definition. The degree of pathogenicity, the relative severity of a disease caused by a particular microbe. How nasty it is. How easily it attaches. How few we call it infectious dose. How much damage it does once it attaches. How hard it is to treat. What long-term complications. So to me, when something is virulent, virulent doesn't mean virus. Virulent means anything. Okay, virus is even though it sounds similar, it's not the same. So virulence, all of these different virulence factors. So how easily it can get on you, what kind of damage, any characteristic or structure of the microbe that contributes to its ability to establish and cause damage. It's a very generalized definition. So you're going to see things like infectious dose. I talked about it just a little before. And you'll see in a second what it means. A lot of infections are what we call polymicrobial, meaning that, and I don't know, I think majority is probably a reach, okay, means more than one, okay? So that is not polymicrobial. Maybe according to this little major PowerPoint, major cause of the major risk of getting the flu is secondary bacterial pneumonia. So that's a secondary infection. The primary infection is flu, influenza. The secondary infection is pneumonia. That's the one that can do more damage. In general, viral infections can often pave the way for secondary bacterial infections. Like your ear might start, typical kid's ear infection might start viral and all of a sudden become bacterial. Bacterial is one. Okay, so understand that polymicrobial might indicate that the origin might have been tied to a previous infection or previous damage. It doesn't. To me, polymicrobial means when I culture the wound or the area, I get 2 or 3 or more different organisms that are contributing to the problem. So ignore that for the time being. Several types of skin infections, staphylococcus and streptococcus, I'll buy that. By far and away, most is streptococcus. When it comes to skin infections, staphylococcus would be number 1. These days, streptococcus and probably Pseudomonas aeruginosa might be number 2. Exactly what batting order I would. The staphylococcus would probably be number 1. Okay. Now, Moraxella is a gram-negative. I don't know why that plays a role. Most Moraxella you have in the respiratory tract are considered normal microbes. So again, unless they can give me more information, one bullet is insufficient. When you're doing a project or a paper, you never put just one bullet under a statement. You got to put at least 2, or else that's the kind of thing. If you submitted that for a paper, who's ever looking at it, go, no, get another bullet or get rid of that one. Portals of entry. Okay, a portal of entry is how it gets inside. So does it come from outside or does it come from inside? Okay, so we have things that are in our interior that can cause problems. Gut bacteria lead to a ruptured appendix might be a perfectly good example of that. Most of the time we're thinking exogenous from outside. And what we're going to look at, I don't want to get into it now, we have to look at portals of entry, and most of, but not all the time, are the same as the portals of exit. You get a flu from inhaling something. You cough, you sneeze. Once it's cultivated, that's the damage it causes, and you cough and sneeze and you spread it that way. So there's portal of entry and portal of exit. All right, let's call it for here. We'll pick this back up on Friday. Thank you.